Now we'll start with the case presentation or case discussion. I'll request Professor Zakaria, Professor Ismail sir to please come on the stage. Our panelists are Dr. Anthony, Dr. Debelochan, Dr. Amrish and Dr. Arun. They are here. So the field of ascites and HRS is going a significant change in last 10 years. 10 years before, there was no concept of albumin infusion, terlipressin infusion, NORAD infusion, addition of albumin with NORAD. So a lot of things, addition of oral vasoconstrictors like mirodrin. So last 10 years, a lot of things have happened. How to correct hyponatremia? It's dilutional. Do you want to give 3% saline or want to mobilize fluid? The whole area is dynamic. Initial 48 hours wait with albumin only for patients with suspected HRS has come down. Dr. Aki is in the team with the International Ascites Club and probably they have made it at 24 hours now, what I heard in your presentation yesterday. So it's a very dynamic field. There is nothing absolute truth here. So the case is being presented for discussion to see the way out. This case, what we have done at SGPG, I will be showing. It might not be the same as other centers do that, but everybody is correct in their own way because everybody has significant experience with the way they are managing things. So to start the case, 59-year-old male, diabetic, decompensated for last 2.5 years, worsened since February this year, ascites kept on worsening, did not respond to diuretics, was on large volume paracentesis. So, and he had recurrent hypoglycemia because of complications of furosemide. So not tolerating diuretic requiring large volume paracentesis. In a nutshell, it's refractory ascites, diuretic intractable. July again, he was admitted last month with progressive abdominal distension with history of fever for 15 days and left lower limb cellulitis. So came with infection worsening with oliguria and altered sleep rhythm. He was admitted at a peripheral center. In that center, according to reports, he had flaps present. He had a MAP of 68. Respiratory rate was a bit high, 24 per minute. So the doctors there gave 3% saline infusion and did some large volume paracentesis to correct the sodium. With this, the patient was referred to our center. When we saw the patient, hemoglobin was 6.7, INR was 3.7. Sodium was 117 that had corrected to 123. Creatinine was 2.4. Urinary NGAL was 206, CRP was high, Procal was high, and MELT sodium was 38. We also normally do the hemodynamics baseline. So baseline hemodynamics showed SVR was very low, around 600 odd, and most of the parameters were deranged. MAP was 68 and SVR was low. So this patient had evidence of splanchnic and systemic vasodilatation. Poor MAP, poor SVR, and obviously splanchnic vasodilatation would be there. So here comes the role of simple echo test that can give you a reasonable amount of volume assessment. Plus we also do renal arterial resistive index that was quite high, 0.8. CVP was up 18. So in a nutshell, this was the diagnosis. MELD was high. We had fluctuating HE, tense ascites, sepsis, probably cellulitis. Other workup had to be done to find out the cause of sepsis. So Dr. Anthony is there? Is not there. So anybody can take the first question. How do we assess and prognosticate based on the labs that he has? He has a high creatinine, he has a high urinary NGAL. Do these values give us some idea of how good or bad the patient is? Creatinine is 2.4, NGAL is 206. So as we all know, most of this, anybody please? Dr. Debelochan?
From this, first coming to history, patient is having multiple episodes, as you mentioned, having hyponatremia.
We'll discuss each problem one by
Yes,
one.
sir.
So
Yes,
start
sir.
with prognostication.
Prognostication, obviously, sir, recurrent episodes of hyponatremia, encephalopathy, not tolerating diuretics, multiple episodes of paracentesis, and along with that, creatinine of, you mentioned 2.4,
yeah,
2.5, MELD of 37 or 38. So it is very, prognosis is very poor, short-term mortality is very high, maybe.
So apart from that, creatinine, what creatinine gives us an idea, this from confirmed study, that creatinine less than 3, they may do reasonably better compared to creatinine more than 5. The survival is much worse for higher creatinine, worse survival. So higher creatinine, worse survival gives you one thing, that you have to start treatment early. Waiting for 48 hours for creatinine to improve or with albumin only without aiding vasoconstrictors may not hold good. So higher the creatinine, worse the prognosis. Act early. That was the purpose for this slide. The sensitivity specificity of urinary NGAL 220 nanograms is very good. Sensitivity 90 and specificity 78%. This helps us to differentiate between people who would respond and who would not respond to vasoconstrictors. So these values were added. So this is the standard treatment criteria by ICA. I am sure after the revision that is happening at present, there might be some changes in that. The 48 hours duration may be reduced to 24 hours or less. All of you are very well aware of it. So coming to correction of hyponatremia, Dr. Ambrish, patient had sodium of 117, 3% saline was given, it has reached 122, ascites has worsened, output has not improved. How do you approach a patient with hypervolemic hyponatremia, patient like this? So how would you go about it? And what is your routine practice? It may be different from others, please don't mind, just what do you do, can you suggest please?
So if a patient is coming with severe hyponatremia of less than 120 and patient is symptomatic, if the patient is having seizure, then we straightforward give 3% saline. If the patient is asymptomatic, we follow the other algorithm. We resuscitate the patient, especially with albumin 20% in our unit. We correct hypokalemia also if the patient is having, because hypokalemia can also cause lead to hyponatremia. We treat infection, and then side by side we also order for renal parameters like urine sodium, and we follow the urine sodium analysis. If the urine sodium is less than 20, we take it as prerenal, or if the creatinine is high, we take it as HRS, and we give, along with albumin, we add vasoconstrictor like terlipressin. Even if the patient is having hyponatremia of less than 120, we don't go by the saying that terlipressin can lead to further hyponatremia, because in previous studies it was shown in child-age cirrhotics only terli lead to severe hyponatremia. So we go by that algorithm. If the patient urine sodium is okay, and we think that patient is having creatinine derangement because of some other reason, because this patient is also diabetic, we also see for urine protein and other things. And if the hyponatremia is not improving, yes, we add Vaptans for a short duration, probably 15 milligram OD for 2 or 3 days, and see if the patient is improving or not. If the patient is still not doing well on even after these measures, we also add mineralocorticoids in these patients, especially if my patient is having low potassium with high potassium with hyponatremia. So I add sometimes mineralocorticoids also, and I have seen a good response with these medications.
Very nice, Dr. Ambrish. So he says albumin, terlipressin, mineralocorticoids, and Vaptans. 4 things. Virendra sir.
There are few problems with this patient. One, that MAP is quite low. So we'll have to find out the reason. Maybe this patient is having the SBP.
Counts are high, cellulitis is overtly there, workup has been sent.
So that requires the diagnostic tab should be done. Then second one, apart from the situation where we need, if the patient is having seizure, we can give 3% saline. But there is always a risk of worsening the ascites. And especially when this patient is having creatinine of 2.4, we should never think of adding the tolvaptan, even if the hyponatremia is there. Try to correct it. If the 2.4, some component may be because of CKD also there. So we'll have to, because this patient is a diabetic, so we'll have to rule out that. So this is the situation. The hyponatremia, probably this is sepsis related, worsening because of that. Somebody must have given high diuretics. That is another reason. And now if we correct the infection, then add the albumin, then we can add terlipressin, and then I think this patient is going to improve, especially regarding the hyponatremia.
But so,
Sir,
Yeah, they will
one minute, sir. Sir, this patient also has encephalopathy, what you mentioned, grade 2 hepatic encephalopathy having flaps. And in that also, Vaptans should not be given. In patient with encephalopathy, Vaptans
Yeah.
should not be.
See this, if patient is admitted in hospital, then you have to be very careful. OPD patients we should not. So very close monitoring is required. And especially when there is an encephalopathy, these patients will not take the lot of water, which is a requirement. So in that case, we should avoid giving the tolvaptan.
So we should treat infections. We should give volume expanders. We should add terlipressin, and we should see whether the patient is having underlying diabetic nephropathy or not.
Yeah.
And one thing, sir, I will like to ask here. If even after these measures the patient is not improving, and we think then that infection has come down, so is there any role for taking out free water from the body and adding any furosemide to the terli-albumin combination?
See, again, the furosemide addition will further worsen the renal dysfunction. So this is a problem. In this patient, we should avoid adding any nephrotoxic drug here, unless you are following the protocol which
yes, sir. So may I say? So I see none of the
Pandey
books
is
say
doing
that
it.
furosemide is nephrotoxic. The issue is is furosemide released in tubules or not? For furosemide to be released in tubules, furosemide has to be bound to albumin. Albumin in this septic patient would be oxidized and non-functional. So if you add albumin and furosemide outside the body and give that transfusion, only then would the furosemide reach the tubules. When the furosemide reaches the tubules, OAT1 receptor at proximal convoluted tubules strip the furosemide actively and excrete them into the tubules. Only then would the free water clearance start. If you directly give furosemide without addition of albumin, most of the time, due to oxidized albumin, it may not act and may become nephrotoxic.
So,
So
Dr.
moving with the
Gaurav,
case,
just 1 minute. I fully agree that the albumin which is there dysfunctional in these patients. So should we do, question to Rathi also, do the dialysis or absorb?
sir, we'll
the-
come to dialysis next question. We'll wait for dialysis
Absorb
question.
the
Dr. Raki would
bad
answer that
albumin.
question, sir.
And then start the.
So Raki would
other
answer
therapy.
that question when the dialysis comes. See, because this field is very open, new concepts are coming in. Yesterday, Professor Sareen sir's talk, he said that you may not consider giving albumin in ACLF. This talk is not endorsed by many people, but this is a thought based on his findings. It's a very open field. That is why discussion is happening at present. Maybe we may not be giving albumin as more and more data appears, but at present, centers who are giving are good enough. So coming to the terlipressin early, Dr. Divya Lochan, you mentioned terlipressin when? Would you consider giving early terlipressin or late terlipressin?
Sir, in this particular scenario, there are lots of confounding things are there. Already they have mentioned, sir, this patient is having diabetes since last almost 15 years. We don't know the underlying disease, underlying kidney disease may be there. And
So we gave you few background values
background
here.
values,
You
sir.
did not ask 1 month back creatinine was normal for him.
Yes,
So
sir.
nobody asked, so I didn't say. I thought
Okay.
if somebody would ask, I'll give the answer.
Okay, sir.
So fine.
So
So
then,
1 month back, we
yes,
had 1
sir.
month back report that was normal.
Yes, sir. Okay, sir. Then if it is normal, then anyhow, this early study I went through this from ILBS, and they have mentioned that in patients with ACLF, this patient is also ACLF. So initially you give maybe 12 hours albumin only albumin, starting with 100 gram per day. If they are tolerating, international guidelines are telling you give so 1 gram per kg per day, that is 60 gram or 80 gram, up to maximum 100 gram. That may not be tolerated in most of the patient in our center, financially, and also lots of side effects this patient develop. And after 12 hours, yes, we can start terlipressin. Terlipressin with albumin again will mitigate some of the side effects like hyponatremia all those things.
And that's a problem with albumin, because you read the confirmed trial, up to 30% people developed pulmonary edema and
Edema and-
23% people died because of respiratory
Yes.
complications.
Yes.
So once you give albumin, probably you may require to add small amount of diuretics to
Diuretics.
mobilize the fluid. And plus the dose of albumin that has been mentioned, 60, 80, 100 grams in Western literature may not hold
May
true
not
for
tolerate
us.
this.
It may be 20 grams. It's not that high dose of albumin that we are discussing.
Yes, yes, yes.
Yeah, Dr. Raki, you wanted to say something?
No, I would recommend please read the APASL guidelines. We have clearly mentioned that it is not that you can put a no or absolute no or yes to any drug or therapy. How you use that drug, what dose, what formulation, and so that the harm is not done to the patient.
Absolutely.
The
It's a
basic
very
thing is
dynamic
that,
field
Yes.
based
that
on.
most of these patients are just having small, sometimes they are hypervolemic already in that phase. Oliguric, like sir was saying, RRT. So it is not that we keep doing the same things. We have to move dynamically and don't put ki yes it should be given, yes it should not be given.
No,
It should
yes,
not be
ma'am,
that
yes, ma'am.
way. It has to be based on
Yeah,
the
it has to be a
assessment.
study. There
Is it
was.
yes, yes, ma'am. I agree.
See, the assessment of the IVC is very important in these patients. So the CVP line may not be a true reflection. So the ICU, the hepatology ICU should always have a portable ultrasound.
So with 5 minutes left, we will move forwards. So caveats, adverse effects were excluded. So Ismail sir, would you considering the same therapy or any response guided therapy or IVC diameter or hemodynamic assessment would guide anything?
It has already
It's
been
been
discussed
default,
here.
right,
Actually, we
sir.
have to measure. But the only problem which I would like to tell is that these 48 hours and all came because most of the patients with renal failure is due to fluid responsive renal failure, that's pre-renal failure.
Yes.
So that's why you give volume and then diagnose HRS. But the problem with such patients that with tense ascites, actually the IVC measurement also will be abnormal. So you have to actually tap and reduce the intraabdominal pressure to less than 12 and then assess the IVC. Otherwise you go erroneously because you think that the patient is hypovolemic and you still pump in fluid and then the patient can go into respiratory
Right.
failure.
Very nice. So RARI, renal artery resistive index, does correlate well with MAP and estimated GFR. And once we reassess RARI, renal artery resistive index improves. So of the diameters that we have and various parameters, IVC collapsibility and renal artery resistive index seem to be reasonable in this subgroup of patients who are a bit sick and have tense ascites. So does improvement of MAP help improve perfusion and reduce creatinine? So studies have elegantly showed that a rise in MAP during therapy with HRS is associated with improvement. Again, a very elegant study published this year to predict the response to albumin terlipressin. They said SIRS and MAP on day 1 and delta RARI change at day 4 would help in improvement. This was one of a response guided therapy. I started doing that under guidance of Ismail sir. He has been my mentor. So we started giving albumin and terlipressin early and started giving furosemide with that. So initially we thought that we saw that people who improved within 48 to 96 hours, they had a much better prognosis. Probably they had less severe pathophysiological dysregulation compared to people who had higher dysregulation and responded early to vasoconstrictors and albumin infusion. GFR improved, RARI improved, and they poured out. So probably this could be a surrogate marker. People not improving at day 3, day 4 you could consider counseling for transplant and going ahead, because hemodynamics has not improved with high dose of vasoconstrictors and albumin with furosemide. And obviously with this therapy with vasoconstrictors, RARI does improve. So in hospital course, MAP had improved. Just a couple of minutes, we'll try to rush through that. Sodium had improved. The issue was MAP had not crossed 82 that we keep in our study. So here, instead of going ahead with terlipressin, we had a small dose of NORAD for synergistic effect. Here we saw that the SVR was very low. SVR was 600. These patients would have SVRs like this. Instead of pushing up terlipressin, there can be a case of adding small dose NORAD to get the SVR corrected. Terlipressin more on splanchnic, NORAD more on systemic, alpha-1 agonist. So you will have the same value. So patient initially with this therapy, urine output improved. Suddenly at day 10, there was a dip in urine output. Cultures were sent. He was found to have SBP and that was multi-drug resistant. So Dr. Raki, MDR has a very bad prognosis. Study from ILBS about GCSF addition to antibiotics. Would you throw some light on that?
Adjunctive GM-CSF was shown in difficult to treat SBP, but the the entry criteria did not include at that point of time MDR or XDR bacteria, and there were patients, none of these patients were in the ICU. So they were all hospitalized patients.
Yeah, so these are
So
similar
less
to
sick.
these patients.
Yeah.
Multiple admissions outside, multiple antibiotics has
So
come with the game.
carbapenem was given
Yeah.
along with adjunctive GMCSF, so that is one strategy which can be tried.
So what dose duration?
Duration was, it was given as an infusion and 0.5 mg microgram per kg per hour, and it is given over 5 days. And then we do not know, what we see clinically is that there is a reduction in the neutrophil count, and the SBP resolves even at 24 hours based on the neutrophil count. But subsequently the long-term outcomes are not sustained. They do get recurrences, so initial, yes, if you are planning transplant, you can achieve that response and go for transplant.
Right. So role of GMCSF in difficult to treat SBP mentioned by Dr. Raki. Again, taking this forward, Dr. Arun, any role of RRT early or late, as was discussed with Professor Binder Singh sir? Would you like to comment on that?
So renal replacement therapy, once a patient is going for refractory ascites along with evidence of persistent encephalopathy along in the background of severe persistent hyponatremia. So RRT can be considered. Among RRT, rather than going for plex in this kind of scenario, since the patients have a long-standing presentation, we can go for SLED to improve the hemodynamic stability along with rather than combining with the intermittent hemodialysis, so it will be having more beneficial role to go in for that kind of therapy. So SLED will be having more potential role to consider in this kind of.
Dr. Raki, lot of literature from your center, and obviously you are pioneering many of these studies. Would you like to comment on this?
Yeah, so obviously if the resource constraint is there, we go with SLED, but we have to do very cautiously SLED in hemodynamically unstable and these set of patients, refractory ascites. They get hyperlactatemia, they do get hypertension, they do get worsening of coagulation. We do get same problems with CRRT, but it is less. And then another important thing was that early and late in HRS, you should delay dialysis as much as possible.
Very
Because
important.
it is not helpful until and unless, again, you're bridging your patient, you want to bring down some metabolic parameters which are related to uremia. Otherwise, RRT should never be early in HRS. Yes, for ATN, shock patients you have to consider, and for ACLF, an early RRT where you are handling a tubular injury as apart from all the other problems.
Very nice.
Now, with RRT, we are also risking other thing like introducing infections.
What I'm saying.
Yes, ma'am.
But if you delay in patients who are sick, ACLF with shock, you will never get that window to dialyze those patients. In these patients, we should delay as much as possible, and there should be an indication of why we are doing a dialysis for some renal complication which cannot be managed by medical problem.
And even in the background of ACLF scenario, plex will not be having more potential beneficial.
Plex may not be the right therapy. As of now, we don't have any evidence to say for renal dysfunction we should be doing plex, because already we see a lot of metabolic problems come with plex. So we always combine with CRRT if at all we are using plex in
For renal dysfunction. Without renal dysfunction, hyperbole, INR up, we can consider that.
Any
Just to take-
role of adsorbent therapy?
Adsorbents are very safe, and we have actually moved in the ICU from plex to adsorbents and CRRT, because if you add adsorbents to CRRT, specific filters are available for several, whatever molecule you want to target, and very, very good, very safe for the patients. The only problem is, even when using adsorbents, is we have to be careful and look at the coagulation. If the patient is having severe thrombocytopenia or hypofibrinogenemia, the DIC or the bleeding complications are there. So that set of patients, even adsorbents are not good.
How much is the cost of this adsorbent therapy?
So the cost so normally such patients require, for ACLF, it is very good, for pneumonia, ARDS, refractory shock on CRRT. So we add on that set of patients. The cost is around, what we get in our center is very cheap, 60,000, but the MRP is around 85,000.
Zakaria sir, your comments on this? You all have been doing a lot of plex in this scenario with the...
For the adsorbent, do you need any special instrument?
And we have, sir, like if you have you have to use adsorbents, so there are different companies. So like the Baxter, those who have the CRRT, they have their own Oxyrus. That is around the field. If you start Oxyrus, it is like you are doing CRRT with an adsorbent.
So this can be...
This is around 80,000, but if you do just CRRT, then it is 40,000. But if you add some other filters which are available, so then their cost is like this.
This can be done with the dialysis machine,
So
the
mostly
routine.
if there are two adsorbents, you need two sled machines, otherwise CRRT you need for doing the adsorbent therapy. If there is a single adsorbent, you can do it with sled also. Sled machine.
Sir, your
I
experience.
agree with the panel and the the people. I think we have to be very clear. Here, the renal replacement therapy is for a renal indication, and also with a patient who is septic and relatively hypotensive, probably addition of plex will be more harmful. So I think in this particular scenario, indications of CRRT are for renal indications and not liver.
Very nice. So taking it forwards with antibiotic, things started improving on the same dose of therapy. The output improved and creatinine decreased. There was improvement in MAP and CVP settled. Urine output and urine sodium did improve. So the labs improved. Hemodynamics also improved with mobilization of ascites, endotoxemia, cytokines did improve. This is a standard protocol that we follow in our center. Now, once the patient has improved, so Mr. Vinder Singh sir, any role of addition of midodrine? The patient has had recurrent hypoglycemia and MAP less than 82 for long. So any addition, would midodrine or tolvaptan with midodrine do? Or your recent study from SGLT2 inhibitors has come that you had presented. So any comments on this?
See, how much is the sodium at this stage?
The sodium at this was 126, sir.
126. And are we giving any diuretics in this patient?
So we had mobilized the ascites. Now at time of discharge, he is relatively dry, clinically dry.
See, so this patient looks like, and how much is the MAP?
MAP at present on inotropes was 83, but we would be obviously at discharge stopping inotropes. So he would be going home.
No, stopping inotropes is okay, but you
His
wait for
baseline
some more
MAP
time.
throughout the admission was less than 80. It was 76, 72 recorded at various times at various setups.
And he has developed the recurrent ascites.
Recurrent ascites and recurrent hepatic
and
encephalopathy
hyponatremia.
and hyponatremia.
So this patient will require the midodrine and may be benefited with the midodrine. And but only thing is that there should not be any renal dysfunction.
So creatinine
If
has
there is
settled
a-
down. Creatinine settled down here.
If the creatinine has settled, the MAP is still low, and you are planning to discharge this patient, so we can add a low dose of midodrine. Maybe we start with the 5 mg 3 times a day. And
So do you consider improvement in MAP or a fixed dose of midodrine, sir? Do you want to push the MAP up to above a particular level, or just a 5 mg TID would be enough?
see, 5 mg TID initially, we can measure the MAP maybe after a week, and then after that we can again increase the dose if required. Otherwise, 5 mg, these patients do very well.
Right, sir. Any role of SGLT2? He's a diabetic for 15 years. Would you want to modify OHAs, sir?
Yeah, this SGLT2 is of help in these patients, especially they have ascites, this is a diabetic, so this is going to help. In our study, although it was a small study, which we presented in ASLD last year, and in that the control of ascites was better in the group which was receiving SGLT2.
Smile, sir.
No, I think SGLT2 will be harmful for this patient because it has been shown that initially the GFR will decrease. It is only long-term effects of SGLT2 on kidney. So this patient anyway requires transplant if there is
Yes.
prospects. So if you add SGLT2, I think initially the GFR is going to decrease further and which will hamper the transplant.
Absolutely, sir. So the issue is that is why is there a role of addition of midodrine to maintain the MAP and GFR before we consider adding SGLT2, sir? Zakaria, sir.
Sorry, is the question addition of
Midodrine. You do understand the patient profile. It's not very uncommon to have such patients in OPD. So now the patient has some mild ascites but has had recurrent hypoglycemia, hyponatremia, that is their ascites worsens. So would you consider MAP with diabetes, get the MAP up, get the GFR up, after that stabilize, then add a small dose of SGLT2, maybe change his OHAs before he does that?
So I must say, I don't have personal experience of adding SGLT2, but on the whole, this patient has an advanced CLD and is likely to go into recurrent hypoglycemias as well. So at this point, I would not consider any OHA, including an SGLT, but I would certainly try midodrine in an attempt to try and reduce the dose of diuretics.
What about beta blockers, sir? He has grade 2 unbled varices.
So I think if the patient is still having ascites which is not controllable, at that point I would withhold beta blockers. Once the ascites is controllable, I would consider beta blockers, but I would not give carvedilol in this situation. I would use careful propranolol, see if the patient is tolerating. If of course at some point the patient becomes recompensated, but this particular situation is hypothetical.
So sir, is it possible?
You yourself have said that the map, baseline map is
Yes, sir.
very low.
So that's why there is a recent study that has come, sir. With addition of midodrine, would beta blocker addition be helpful or may not be helpful?
So there is no point in combining the two.
And this study from ILBS that has come recently, sir, on patients with ascites.
I know.
So
On one hand, you are giving the beta blocker, and then you want to give the midodrine. So, see, the problem here is the beta blockers. Still, the things are not clear. ACLF, beta blockers, there are many studies which have shown the beneficial effect. So, but in our experience, whenever there is a difficult to control ascites or development of hyponatremia or the raised creatinine, in that situation, the beta blockers should not be given.
So just moving forward, literature has shown that ascites develops less if the MAP is more than 82. Ascites develops more if the MAP is lower. And this is because the MAP from 80 above, there is auto-regulatory phase of renal blood flow and helps mobilize fluid. So MAP less than 80, more prone for ascites development. And hemodynamic hyponatremia correction, one study showed that if you add midodrine to get the MAP up, there is some survival advantage. In this set of patient, this is Vinder Singh's study that he was talking about, and with addition of tolvaptan. Use of beta blockers. So mixed results, as has been told by panel, Zakaria sir, Ismail sir, and Vinder Singh sir. One of the papers published in 2022 showed propranolol helps in patients with refractory ascites. There was improvement in variceal bleed, risk of development of HCC was less, mortality was lower, and survival was higher. But a paper in J. Hepatol in similar group of patients with refractory ascites did not corroborate the finding of addition of beta blocker in such group of patients. So mixed result, data is mixed, there is no clarity. Our expert opinion panel, Ismail sir, any comments?
No, I would say that the patient has to be listed for transplant first. Second, if his MAP allows, you can start with a small dose of beta blockers and see. And as they said, basically you start with propranolol rather than carvedilol.
Sir, one thing, sir. So this previous study showed the decrease in hepatocellular carcinoma, decrease in varicella. Patient will not survive that long to develop all these complications.
Yeah, so what they
we
found
have
is
to
that 2 years incidence, very small follow-up. That was the drawback of this study.
So sir, what sir told, we have to list for him for transplant first.
So SGLT2 has already been discussed. Follow-up, long-term domiciliary albumin, sir. Any comments from the panel? Sir?
It is after the ANSWER trial that the domiciliary albumin, but it is not, I don't think it is feasible in our setup with in a medium socioeconomic status. One is cost, second is the hygienic, how you can infuse this.
So the cost is actually after the ANSWER trial in Europe, they are with long-term albumin, they are also giving long-term terlipressin with that. In the trial is going on, we'll know the results soon. But there is a concept of the world changing towards long-term albumin with long-term terlipressin to mobilize, to correct the hemodynamics. Yeah, there is a Europe study also is going on. So now the change is towards getting the hemodynamics correct. So sir, your comment on these?
This domiciliary, it was not mentioned in the ANSWER trial.
No.
We should give it in hospital.
In hospital.
Not the domiciliary.
Weekly albumin, sorry, in hospital.
We can, but the only thing is that again the cost is a problem. How many patients will afford? These are patients who are not ready for the transplant. So obviously, probably there is a reason of the money. So how much is the cost of the giving 40 grams of albumin per week? So this is again a huge cost. So this is a practical problem.
Apart from cost, sir, we talk about survival advantage. Would you
this
consider or
is-
not?
See, the answer trial has shown that it was effective. On the other hand, the match trial had not. And we require more and more. The Pascoli trial also again showed that it
Yes.
is useful, but we require more and more studies.
It's 9 o'clock. Oration is going on now. We'll close this session. Thank you all for participation. It has been a pleasure interacting with you. Thank you so much.